The views expressed on the NCS podcast are solely those of the hosts and guests and do not necessarily reflect the opinions or official positions of the Neurocritical Care Society. Hi, and welcome back to the NCS podcast. This is Lauren Kaufman. I'm a neurointensivist at Temple University in Philadelphia, and today I'd like to welcome onto the podcast an author from a recent Currents article, The Role of Ultrasound-Guided Lumbar Puncture in the Neuroscience Intensive Care Unit. So thanks, Swarna. We have Dr. Swarna Rajagopalan, who's a neurointensivist at Cooper University Healthcare. She's also one of my good friends, so thank you so much for joining us today.
Yes, hello. It's a pleasure to be here.
So, I'm aware that you are really into using ultrasound in the ICU and do it quite often, and you're pretty involved in different committees and societies on using ultrasounds. But maybe you could just tell us a little bit about why you have an interest in it and what kind of additional training you might have.
Yeah, that's a great question. So my interest in ultrasound first started when I was a fellow. When I was a resident, we did not use ultrasound for central line placements. I didn't even know that was a possibility. And when I started fellowship and started using ultrasound, I discovered the world of being able to see or visualizing the anatomy of the procedures. So that kind of opened my eyes. And when I was a trainee, my fellowship program director at the time, Dr. Atul Kalanuria, was very interested in ultrasound as well, and he incorporated it into our curriculum. So that kind of piqued my interest more. And then when I was a senior fellow, I was in charge of the critical care and neurocritical care didactics. So I included quite a few ultrasound topics, including ultrasound and point of care ultrasound in shock and resuscitation, and some of the other neurocritical care indications, including procedural ultrasound. So yeah, that's where I would say my passion first started. But in terms of experience and certifications, so I think most of my experience with ultrasound was actually as an attending. When I started to use it more in practice, especially surrounding pericardiac arrest, post-cardiac arrest, that's kind of where I started the most, because those were some of the few indications in fellowship that I saw it meaningfully in front of my eyes make a huge difference, see a huge clot in transit and being able to give a fibrinolytic and getting ROSC. Some of those things stayed with me. And as an attending, I started to use it more initially through, shock states, hypotension, and more of the medical indications. And then I started to think, if we use it for the Saldinger technique and procedures such as central lines, why not try and use it for some other indications, such as lumbar punctures? So I started exploring that as an attending, and then I found it really helpful. And then it got up to a point where I only do lumbar punctures now with ultrasound, because I find that, anecdotally, it improves the first pass success. It causes patients less pain because it's less needle entries. And this is also supported by data. There was a big meta-analysis that looked at ultrasound-guided LPs versus anatomy-based LPs. And the number of failed procedures were much lower in the ultrasound group, with a number needed to treat of 16. So it was pretty impressive. And I think some of the things that haven't been looked at in detail are, the amount of time it takes, right? I think that's sort of the biggest hesitancy. And I see that amongst trainees, even think about it for a second. Do we really need ultrasound? Because I have to get the machine, then I have to put the probe cover on it, I have to put the gel in. But I think, weigh that against multiple failed attempts, I think you still come out ahead. It hasn't been proven, but one of my residents is taking the initiative to look at that on all the lumbar punctures that we've done at our institution.
Awesome. So, you've covered some of the evidence that exists to support using ultrasound guidance for lumbar punctures and some of the, practical implications that, we can do it faster, more comfortable for the patients. But like maybe you can explain to us for people that haven't ever used ultrasound for lumbar puncture, like what does that look like from the technical side of things? Like what landmarks are you using and like how are you integrating that into your procedure?
Yeah, so that's a great question. So typically the probes you can use for ultrasound guided LPs are either the high frequency probe with low penetration that gives you really good resolution. So the same probe that you would use for vascular procedures, the linear probe, because it gives you greater resolution. But in most ultrasound machines, the depth for that is limited. It's usually about 6 centimeters. So that's my first go-to because it gives me the best resolution. So if the patients are, anatomically don't have a high BMI, I often don't need to reach for the bigger, deeper probes. So that's usually where I start, at least to look. And I often will look before I start getting sterile just to see. And I do the same thing with, central lines. I look to scan for anatomy. Um, and so I look first and I try to look at the anatomy. That tells me which probe I need to use. So with the linear probe, I will start initially in the transverse view to try and identify the midline. And so the spinous process can be seen as a hypoechoic structure in the middle of the screen. And that tells me at least that I'm at midline. And at that point, depending on the trainee may choose to mark it at that point. In my experience, once you get sterile, it often gets washed away. So I often don't bother, but some trainees like to do that, and they'll mark along the midline at multiple levels. So this is actually really important because I find that sometimes patients that have scoliosis or lordosis, their midline is not straight. So this actually helps us identify exactly what their anatomical midline is, and then we're often able to see if they had previous surgery or if there's bony fragments there that are interfering. We will avoid that level. So the first step is to identify the midline. Now, if the patient has a higher BMI and the high frequency probe is not working, then I reach for the lower frequency probe. The cardiac probe would be fine. I usually put it on the abdominal preset. And again, look at it transversely to try and identify the midline. And once the midline has been identified, then, and I know which probe we're going to use, we get sterile. And then I usually, the only two additional things in addition to the LP kit that I bring in are the ultrasound machine with the gel and the gel cover and a marker, sterile marker. And so we get sterile. We repeat the same thing, this time marking the skin after the patient is already sterilized. And then, so first transverse view, identify the midline. Once the midline's been identified, on the longitudinal view, then I look for the ligaments. I find are harder to identify. Sometimes if calcified, they're really easy to identify. But for the most part, what I'm looking at is the interspinous process. So between the spinous processes, there's a dip on ultrasound that you can see. If I describe it to trainees as two mountain peaks and then a valley, and that valley tells us exactly where we need to go. So now we're marking it. So we marked it first, marked the midline. Now we're identifying exactly what level to go on. And when we are looking at that, we're also, what I like to do is I like to ultrasound for the sacrum because it looks anatomically very different on ultrasound than the lumbar spine. And then we count backwards to identify the exact level that we're going at. And my trainees will often mark, L4, L5, and, L3. And then that way in the procedure note, they can say exactly what level they went at or what levels failed. Yeah, and the rest of the procedure is identical to the anatomic palpation technique.
Cool. And so, you mentioned that you're kind of looking within your own institution in terms of how this is potentially benefiting patients. So, what about the training? Because, you've mentioned that you're doing this pretty much exclusively now, with the ultrasound guidance. I'm just curious, are other people in your group, have they moved along to that as well? And is it kind of standardized for your trainees, or is it something you're hoping to move towards?
Yeah, no, this is something that I like to do, but it is not uniform amongst the other attendings, so there's variation. And I think it's important for the trainees to get training on it, though, because they also do lumbar punctures in areas that are less supported, like the floor, outpatient clinic. And it actually has led to such a surge of interest that even the outpatient clinic and the floor is trying to acquire ultrasound machines now because of the reasons that I previously stated. Less number of attempts, faster needle entry, and then hopefully less pain.
So, thanks for explaining that. One thing I think we have to consider in medicine these days are, the cost and any potential benefits for what we're doing and how we're doing it. So, are there any
Exactly.
potential advantages in terms of billing for this procedure if we're using an ultrasound?
That's a great question. So any procedure that you do ultrasound that you use ultrasound guidance for, you can include a code that I think it's CPT 76937. It's the ultrasound guidance for vascular access code or the ultrasound guidance for needle placement code, depending on what procedure you're doing. And if you're using that and you say that accordingly in your procedure note, it can be billed as such by the coding department in your hospital, or if you're billing yourself, there's specific CPT codes for each.
You've made it seem pretty easy to use. It sounds like through your experiences, and there's a lot of excitement for incorporating this into doing our lumbar punctures. Do you think there are any barriers to implementation that people should be aware of?
I think one of the barriers that I kind of alluded to is the concern for time, where people are afraid of the extra time that it might take. Training, I think, is the biggest practical barrier because, like I said, even within my institution, there is variability amongst attendings and ultrasound usage, and different people trained at different times and ultrasound usage wasn't really common when a lot of neurologists did their training. So I think, and this was again not just pulling it out of thin air. There's a survey that came out fairly recently that highlighted that there is a lot of variability amongst neurointensivists and ultrasound usage. Only 42% of the people that responded to that survey through the Neurocritical Care Society felt skilled at acquiring images. And these are people that use ultrasound. So there's, I think training is a big piece of the comfort. And I think that currently is probably the biggest barrier. And of course, cost, like you said, but most ICUs have ultrasound machines these days. So hopefully that it wouldn't really add to cost.
Going back to your the initial like passion and enthusiasm you found for ultrasound, it started kind of more with general critical care, shock states. Now we talked about the using the ultrasound for lumbar punctures, but are there any other neurospecific procedures or diagnoses that you think it can be really useful for and underutilized?
Yes, I'm so glad you asked that question. There are so many indications for ultrasound usage in the neuro ICU specific to the brain. I sort of think about it like how we used to use the stethoscope and now it's phased out by point of care ultrasound. I sort of think about it the same way for the brain. I think, even determining optimal cerebral perfusion pressure goals in patients, I think one thing that gets left out is their individual physiology and they're specific to their disease, which is dynamic and evolving. And the brain is complicated. And one size fits all approach, I think, is might simplify things a little too much. And I think using physiological based care might offer some new insights into the physiology that we're treating. So using ultrasound for that We sometimes do point of care transcranial Dopplers. I've particularly found it useful in patients post revascularization surgery to determine optimal blood pressure goals and also to assess their cerebral autoregulation at the bedside. By the way, please, this is putting a plug in here. Check out my manuscript that was just accepted on cerebral autoregulation at the bedside, where I go into some of the techniques that you as an intensivist can use to determine cerebral autoregulation at the bedside and then decide what the optimal goals should be for that particular patient. So yes, I think transcranial to answer your question, I think transcranial Dopplers in the neuro ICU can offer a lot of insight on brain physiology.
Awesome. So now you have a lot of experience with this, something you're passionate about. For someone that, whether they're in training or they're already in practice and they just aren't as comfortable using the ultrasound, are there any resources or courses that you might recommend for people to become more familiar with, all of these different applications?
I think the first step I would suggest is join our section in the Neurocritical Care Society ultrasound section. I'm currently the co-chair, and I welcome you to join if you are an enthusiast or you're semi-curious. Please join us. We often talk about our passion for ultrasound, but also we have joined forces and participated in multi-center projects and expanded global research and work together to think about ultrasound usage, incorporation within ENLS and more within neurocritical care if it's possible to standardize that for education, and also in resource scarce areas where they don't have access to neuroimaging readily. And Dr. Kaufman, you're going to be accompanying me to Tanzania, where I think I did a quick questionnaire to see a needs assessment to see what type of education they would like in addition to ENLS. And one of the biggest topics they requested was some ultrasound training in point of care ultrasound for the brain. So I mentioned transcranial Dopplers, but even traditional B mode ultrasound can help you identify midline shift, help you identify intracerebral hemorrhage, can help you identify a lot of catastrophes that we don't typically use when we have CT or MRI that we can acquire quickly. But in resource limited areas, I think this becomes a higher priority. So that's a really big usage for it.
Awesome. Yeah, I'm super excited for our trip, and I'm going to be learning more about ultrasounds and all of their applications as well. Are there any other, parting words you want to share with our listeners about ultrasound and, things we should think about in terms of how we use it in the ICU?
I think just use it more, just put your hands on the probe. It's one of those things that becomes muscle memory. It matters a lot, how you're fanning it, how you're rocking it. Those micro movements really matter. So it's not something that you can just get from a textbook. I think it's important that you put it to practice. And I think much like myself, I think I encourage you to pick up the probe and start using it and start practicing. But in terms of resources, I'm sorry, I think you asked for that before. For transcranial Dopplers, Dr. Arthi Sarwal does a great course. She's since left Wake Forest, but the course is still alive. It's a joint course now, and it is formative, excellent. I've taken it, and I encourage you to also explore that. I think Swedish Hospital in Seattle also offers an excellent course. These are, the two big courses that I'm aware of. There may be numerous other ones that are also very good.
Great. And so for anyone that is interested in joining your ultrasound group that is within the Neurocritical Care Society, how does someone become an active member? What do they have to do? Where do they have to go?
So the first step would be to join us through NCS Connect, and then you can feel free to reach out to me. or any of the NCS correspondents who can add you to the group invite. We meet on Tuesdays, 4 p.m. Eastern Time, I think the last Tuesday of every month.
And just a reminder that at the annual Neurocritical Care Society meeting, we have an ultrasound workshop that we're running this year. This would be a great avenue for anyone who's looking to learn new skills, seasoned attendings who are looking to brush up on their ultrasound skills. So that would be a great place to join us. And then we're also hosting a sponsored happy hour. So please join us for that as well after the workshop.
Great. Thank you so much. Really appreciate you joining. We'll make sure we include a link to the article in the show notes. To check out this or other Currents content, head to currents.neurocriticalcare.org. As a reminder, NCS offers free CME for select podcasts. Listen via the NCS Learning Center and complete a short survey to receive your credits. And don't forget to add us to your favorites.